Hi, and welcome to the Conversations About COVID seminar series. I'm Jessie Burke. I'm Associate Dean for Academic Affairs and Faculty in the Department of Behavioral and Community Health Sciences. This is a seminar series that we held earlier this summer and brought back again this fall. And what I appreciate most about it is that I get a chance to learn from important research that's happening and work that's happening at Pitt Public Health and in the area around COVID. And I want to take a minute to encourage you all to look at the school's COVID-19 webpage to view recordings of previous sessions and to explore some of the news segments about how our faculty, staff, and students are all involved in addressing the pandemic. So a little bit about today's structure for the webinar. So I'll do introductions and then the speakers will discuss the topic and we'll open it up for questions from the audience. Please use the Q&A function to ask your questions and we'll help to moderate from there. It's my pleasure to introduce our guest speakers. So Chantele Mitchell Miland is a doctoral candidate in the Department of Epidemiology at Pitt Public Health and is actually defending her dissertation this semester. So we're super thankful that she's spending some time with us. Her dissertation work examines health-related quality of life among obese individuals undergoing weight loss treatment. She's also a research health scientist specialist at the VA Pittsburgh Healthcare System, Center for Health Equity Research and Promotion, and Mental Illness Research Education and Clinical Center, where she works with the Equity Capacity Building Corps. After she graduates, she plans to continue research among obese populations with a lens towards health equity. Earlier this summer, the COVID article that she and Dara Mendez, faculty in Epi, co-authored in the Pittsburgh Current really caught my attention. And in fact, it was a line that said, let's be honest, we're tired when talking about the COVID pandemic. And it really resonated with me and I appreciated how that admission drew the readers in to an article that was really filled with information, explanations, and calls for action and policies to protect Brown and Black individuals from COVID-19. I'm really excited that she accepted our invitation to talk with us here today. I'm also pleased to introduce our second speaker. He's an alum of the MPH program in Behavioral and Community Health Sciences. In fact, he graduated right when I started here in 2005 and has maintained really strong connections with the school and the university and a commitment to diversity and inclusion. Mario Browne is the director of the Health Sciences Diversity, Equity, and Inclusion at the University of Pittsburgh Office of Health Sciences Diversity. He's also interim associate dean for Equity, Engagement, and Justice at the School of Pharmacy. And in addition, I just recently learned that Mario's own health habits center on bicycling and that over a decade ago, he co-founded the Pittsburgh Major Taylor Cycling Club. It's a club that promotes cycling to inner city youth, taking young people on weekend bike rides and instilling healthy habits and giving bicycles to kids. I really appreciate that you're both here with us today and taking the time to discuss COVID-19 and health disparities. So I will stop sharing my screen now and I will turn it over to Chantele to start our conversation. Chantele.
Okay, I'm here. Sorry.
That's great.
That's in front of me. Let's see, I'm going to start the video. Okay. Hello, everyone. I'm going to share my screen. Okay. And okay. So we're here to talk about health disparities in COVID-19. And so the first thing that I just wanted to orient everyone to is what a health disparity is, just so we can all be on the same page. So Healthy People 2020 defines a health disparity as a particular type of health difference that is closely linked with social, economic, or environmental disadvantage. And so one of the things, I'm not sure if people have noticed, but when the COVID pandemic started, we didn't have a lot of data other than age. So we didn't have data on race and some of the other things that would have told us about disparities among COVID infection rates. And so there was more information collected, but we still don't have a lot. We do have more information on race now. And so this slide here just shows the COVID cases, hospitalization, and death by race. And so what we can see is that for every racial group other than whites, that there is a higher risk of either being a case, being hospitalized, or dying, except for Asian non-Hispanic persons with regard to death. So going on to the next slide. I just want to run through some statistics here to sort of orient us to the problem. And so this is Allegheny County data. I'm just going to run through some of the Allegheny County data that's up to date. So all of this was last updated October 22nd. So this slide just shows cumulative tests per 100,000 population. And so what it's showing us here is that Black individuals are more likely to have been tested for COVID per 100,000, and they have had more tests than their white counterparts. Other tests, so I don't know if you all remember, but when Allegheny data was first collected, they were not collecting race. That wasn't started. They didn't start collecting that till later, so they still have some people that are not classified. And then people who are Asian were less likely. And then going on to looking at more Allegheny County COVID cases. So for the cumulative cases, what we see is that African Americans were at least two times likely to have be a case compared to the white counterparts after per 100,000 people, but that individuals who are Asian are their numbers are rising. And then looking at cumulative hospitalizations, so we see that there's a major disparity there for Black individuals compared to white, Asian, and others. And when we look at deaths, again, we see that there is a pretty big disparity there between all deaths, white individuals and Asian individuals. And then when we look at age, we see what we see the norm, what we would expect. So individuals who are older are experiencing more or have more cases than those who are younger. So those who are above 70, and these are cumulative cases as well. And then I believe this one. Oh, this is per 100,000 people, so this is standardized. And it's still showing us that individuals who are older are more likely to be a case. And then for positivity rates, when we look at that by race again, what we're seeing is that per this way, let's see. I don't believe this one is standardized. So it's just showing the raw numbers. So Asians are more likely to have positivity than Black individuals, white individuals, or and then the positivity rate is actually lower. The average positivity rate is lower than that for white individuals, Black individuals, and Asians. So this must be standardized then. And this last slide that I wanted to go over, this data is not current. This is data from June. But one of the things that I wanted to show is a concept of intersectionality. So this occurs when we have two identities that might be marginalized or not, and they're intersecting. So what we're seeing is that for all of these, for all tests, for cases, hospitalizations, and deaths, Black women are the highest on this list for most of these. So if we look at all tests, Black women have had some decline by age group, but still within the younger age groups, Black women are more likely to have been tested. And then for cases, younger Black women are more likely to be a case. And for hospitalizations, we see that Black males are actually more likely to be hospitalized as the age increases. And for deaths, again, we see this trend for Black women where as Black women get older, they're more likely to die. And so that's something that we would expect, that older people are more likely to die. But this is more so with Black women. And so I kind of wanted to make a shift from that, start talking about why might we be seeing these disparities. And so one of the main things that we talk about is social determinants of health. And so these are factors like economic stability, neighborhood and built environment, so where we live, health and healthcare, or access to care, if we even have healthcare, how hard or easy is it for us to get an appointment, education, and then social and community context. And so I just wanted to elaborate on what Jesse had said about the article that Dara and Dr. Mendez and I have written together, because we did talk about racism specifically in terms of the racial disparities and how individuals who are in marginalized communities or who are under minoritized, as we refer to them at times, often don't have the same ability to get care, or are essential workers and don't have time off when they're sick, so they're not able to prevent themselves from getting sicker, don't have access to care, or are turned away. And so these are major issues that keep these disparities going. And so when we think about health disparities, the previous slide that I had showed you was a little bit of a simplistic view, and this one is a little bit more, shows the complexity of looking at social determinants of health in terms of how all these things might play out, and having someone be more likely to die, to be hospitalized, or to become infected than someone else, especially if they are in a minoritized or marginalized community. This also highlights how there's still data that we're not looking at. So we're certainly looking at gender, but we're not looking at other things like there's not a lot of data right now on neighborhood and COVID infection. There's also not a lot of data that I'm aware of on income. And so as we move forward, we are thinking about like moving toward a model of health equity. And so that means that everybody is able to get the care, resources, and things that they need, so that they're able to be less likely to have a health disparity. And so with that, I wanted to invite Mario to talk about his work and comment on what I just spoke about.
All right, thank you very much, Chantele. Thank you, Dr. Burke, for the invitation to you both, and for all of my colleagues in the Graduate School of Public Health. Whenever I have a chance to be with you, I always feel like it's coming home. However, I do stay in touch. I have the honor of co-chairing the Community Research Advisory Board there at the Pitt Public Health. And that really keeps me grounded and rooted in my public health roots. But I just want to really make some comments and talk about things that we are doing. And you can take that slide off and stop sharing if you like. In terms of anti-racist work, the work that we've been doing at the university, and really what I see as one of my colleagues calls it, people talk about the multiple pandemics, not just COVID-19, but what COVID-19 has really done to expose and amplify what I call the syndemics, multiple pandemics that are happening, that we're all dealing with right now. And the fact that we are, I think, more aware than ever that racism plays a crucial role in terms of as a social determinant when it comes to the inequities that we see, not just in COVID-19, but that we have seen, quite frankly, for a very, very long time when it comes to chronic diseases. Not just who gets the diseases, but who gets treated for them and who gets access. And I think here at the University of Pittsburgh, one of the things that we can do, one place where we can make an impact, which is how I got into public health in the first place, was to actually look at root causes. And when we think about the work that we do, not just research, but we also educate, we teach, and we train. And what we have been really involved in, my office, along with the Office of Diversity, Inclusion, and Equity, and others within the schools of health sciences and across universities, such as the School of Education, School of Social Work, is that we've really been educating one another and amplifying this issue, that we need to do a better job of looking at ourselves, looking at our own institution through an anti-racism and health equity, or not just health equity, but an equity lens. And what I mean by that is that we've been actually been called to task to look at where in our curriculums have we been promoting and perpetuating racist ideas. So oftentimes when people talk about anti-racism, we often think about whether or not an individual or a person is racist. If we see minorities being affected most by COVID-19, people will say, well, yeah, it's because of racism. Well, what do we mean by that? How does it show up structurally and in our systems where we keep seeing these same outcomes and same results? And so what we've been doing, a few things we've been doing. One is the town hall series that I've been involved in. This is not new. I remember early on in this pandemic, folks began to say, I guess we're going to have to get used to the new normal. And it became very clear that this is not normal. The way that we are living, the way that we're functioning, the way that we go about our day-to-day tasks. I was joking about the fact that this will be my fourth sort of facilitated or co-facilitated or teaching thing that I've done today via Zoom. So we spend hours at a time on Zoom. This is not normal. The way that we have been functioning and trying to make sense of the world, the way that we are living through stress, which is really one of the things that I think we need to focus on. Stress and our mental well-being as a result of COVID-19 and the way that we operate. But essential to that is in the way that we operate at the University of Pittsburgh. So again, one of the things that we've been doing is having town halls on this series. This is not normal. Allyship and advocacy in the age of COVID-19. And what we've been doing with these town halls is really getting at the various social determinants, things such as the political system. We know that we have been in a crazy political year. And if anybody watched the debate last night, you know that we are still in a crazy year. Hopefully it won't be as crazy come November 2nd. One thing's for sure, something is going to happen. And we can only wait and see what happens after that. But on top of COVID-19, we also have seen a spike in, well, I don't know if it's a spike in, but we're certainly more aware of violence, of anti-Black police violence and brutality. And we've also seen a amplification of white supremacy in America. And so all of these things, it's really interesting to me that all of these things have happened since COVID-19. We have had other precipitating events in our contemporary history. One of those I always like to refer to was the Katrina. And by the way, if soon-to-be Dr. Miland doesn't mind me mentioning this, that was around the time that I met her when she came to Pitt and came to Pittsburgh from New Orleans. And I've known her since then. And so what we have, one of the things that reminds me of is that particular incident showed the underbelly of racism in our country. It exposed the inequities and the differential treatment based off of nothing more than skin color, a social determinant, and who got resources, who was able to leave, who was able to come back, and what they came back to. I see the same thing with COVID-19, only to a greater degree. Why that is, I'm not exactly sure, but I do know that we have had the perfect storm. We have had a perfect storm of political unrest, of social unrest, of violence being amplified. And we have really tried to talk about these things in a very honest and real way. One of the things that Chantele and I share is a love for dialogue, talking across differences, having difficult conversations. And through our town halls, we've really tried to bring academics, clinicians, practitioners, and people who are on the front lines doing grassroots work, all on one platform to talk about and grapple with issues of disparities in education, both secondary education, higher education, talking about curriculum, but also talking about issues when it comes to community development. Where does the money go? Things of that nature. So I think that we are at a point in history where it is, there is a great opportunity before us to begin to expose the things that many of us have not wanted to talk about, but now is the time to talk about them. I am proud of my university in this sense, and that is that our students have challenged us all to take a look at the history of our university, the history of our city, the history of our curriculums, and make sure that we are trying to undo all of the lies and the misinformation that we have been passing on for generations. One case in point, and I'll pass this back to Chantele and Jessica for questions and Q&A. That is that some of our faculty members in pharmacy and in medicine have had their students doing book studies, such as medical part-time, and then we have facilitated discussions around them. But the students have also asked for faculty to create spaces for students to be able to talk. A couple of faculty in the School of Pharmacy have decided that they want to look at things such as the estimated glomerular filtration rate, the EGFR, and look at whether or not that is rooted in science or was it rooted in some type of racist ideology. I think for all of us who there's not a lot of science involved, there is a lot of ideology. However, we continue to teach the same thing to our students. So those are just some of my passing thoughts. One last thing I will share too. Right before I came on this, we were doing an interprofessional forum with about 800 students, and typically we do a case to look at to emphasize how all of the health professions actually work together. One of the things that we did this time, and I will take some credit for doing this, and that was I challenged our committee to, first of all, incorporate COVID-19 as the case study, but also to look at where to try to figure out a way to structure the case study such that we can get our students to begin to look at not just patient and provider interaction, but look at structural issues and look at structural racism as a way to see how some people get treated one way in their encounter with the medical system, and how some people get treated another way, and how people do not get the same quality of care, and what might be some of the structural issues that are involved in it. I have a lot of confidence in our students because they are on the ball and they picked up on these things, and they're not afraid to talk about these issues. I would say to you all, continue to press us and continue to challenge us on these. And this is not a matter of groupthink. It's a matter of having honest and real conversations that are holistic in nature, that we can really dissect the way that we do business and begin to make things better. Because ultimately, as health professionals, it's all about our patients, it's all about our populations, it's about the people that we serve. So I'll stop there.
So thank you, Mario. I'm trying to fix my camera. So I had a follow-up question. So first off, I want to say to our viewing audience that Mario is so committed that he is in fact doing this call from the back of a car right now. So it may look like he's in the Cathedral of Learning, but he is actually traveling down the highway. So we really appreciate it, you taking the time and your commitment. I also just wanted to acknowledge that if there was a moment of audio lag, it was just because we are dependent upon satellites, et cetera, to help us out here. So, so far, so good. So I really appreciate what you were saying in terms of how do we have these difficult but important discussions, right? And you just said something that struck me, that students are willing to push and are not afraid to talk. I'm not sure that's the case for faculty and staff and others. And I was wondering if you could talk us through a little bit about recommendations, ideas, things that you suggest that will help us to have those conversations. While on the one hand, the facilitated piece is amazing, on the other hand, I want to grow my own skills too, and wondered if you could talk a little bit about that.
Yes, absolutely. And by the way, I want to say thank you to my wife who is driving, and my daughter who is keeping me company, and that's why my head is bouncing up and down as I'm riding in the backseat.
And sorry, Mario, before you respond, just to everybody else, if you want to put questions or comments in the Q&A, that's how we're hoping that we can have additional discussion, conversation, dialogue, and we'll do our best to facilitate that. So sorry, please.
Oh, absolutely. So yes, we must, so let me see how I want to phrase this. I will say that people do want to talk and have conversations. Oftentimes, it's a matter of not knowing where to start or having a fear that I'm going to say something wrong. Chantele knows, we have this group in Pittsburgh, and what we have established is our ground rules. And that is that we have to give everyone some grace to be able to step on our tongues, put our foot in our mouth, because we just don't know what we don't know. But part of the courage, I think, Jesse, is being able to admit what you don't know, or at least admit what you think you know. And so it's really about being authentic, creating a place and a space and encouraging people to be authentic. But what is really important to get something, to get a dialogue, to get people to begin to think through things is to do what we do in academia all the time, right? Is to give people something to digest, whether that is a book, whether that is some research, an opinion piece, something current in our society, but to give them something to begin to wrap their minds and heads around, and then ask the tough questions. And I would say, Jesse, the hardest part to do this work, I think, is even within our own families. So when people ask me, well, where do I start? I often say, start where you're at. As one of our colleagues and friends wrote a book that said, start where you're at, don't stay there. So once you begin in sort of your comfort zone, or maybe it's not your comfort zone, especially at home or in your community, but then begin to take it someplace else. Take it back to another part of your sphere in terms of your office, whatever it is you want to do. I'll say this, that when I first began to do this work, it was, when I first became interested in dialogue, I was a student. 2004 in the Graduate School of Public Health, and I went to present my barbershop at a conference in Michigan. And I happened to stumble into this group, and it was an intergroup dialogue group. And the topic on the table back then was, are marches and sit-ins viable strategies for civil unrest or civic engagement today? And the two opposing points of view were two opposing identities on that were in the group were sort of these young, very polished young scholars, PhD type, people like Chantele, young and smart and full of energy. But you also had some folks from the 60s and the 50s who were actually in the old guard and did that stuff. And so they really spirited conversation. But at the end of it, they both had more understanding of where the two parties were coming from. And that was basically an all Black group. But the difference was in their age and the generation view. I think if we just create some intentional spaces for faculty to be able to come, if you want to speak, you can speak. If you don't want to speak, I think that we can actually get somewhere. And it's really just about starting wherever we're at and making it a friendly place where it's not threatening. We're not looking to out anybody. We just want to have a dialogue and conversation. Chantele, you have anything on that?
So I again am grateful to being invited to present here, and grateful that Mario is speaking from the back of his car. And I've learned IGD from Mario and Marnie. They taught Dr. Bertolet, they taught the class together. And I think that for me as a student, it was very powerful to be able to engage with faculty in that way, where I could learn from other students that were in the course, and then also from faculty. And there were students from many different racial, socioeconomic. There were only 4 of us, so there weren't too many, but so different racial, and so it allowed us to be able to learn from each other and have more of a safe space within the university. And I think that was very helpful too. And so I think that having, even if it's not just for the faculty, well, not just limiting it to the faculty, but finding spaces in which faculty and students can engage too, and sort of talk about that power dynamic.
Yeah, so along those lines, I am curious, Chantele, if you can talk a little bit about the social determinants of health and sort of an ecological approach to health and well-being. Makes so much sense conceptually. Like, of course, we are influenced by multiple layers and our interactions, but that has gained more attention recently, which is great. But if you could just talk through a little bit more about how that's connected really to this idea of it's racism that is the reason for COVID-related deaths and other health issues, and how that's connected to social determinants of health. That would be great. I think it's again this idea of part of the goal of this series is to help us talk and think through things, and the notion of social determinants of health is not always one that all health providers or healthcare providers go to first as the reason for illness and disease. So if you could just talk to us a little bit about that, that would be great.
Sure. So the idea of social determinants of health is that there are factors or environmental, I'll leave it with factors. There's factors that occur as we're born and as we're socialized through life that have an impact on our health. And so that means, for example, if you're born into a rural neighborhood or rural community, that might have impacts on your access to care, which might have impacts on your health. So for example, if you're born with disability, you might be less likely to get care than if you were born in an urban area. Or in a suburb or more wealthy area. So there's income, race, and where racism comes into that, or social determinants of health in general, is that it becomes a structural issue in which our policies are developed so that certain people have certain experiences. So if you have more money, if you're born into poverty versus if you're born into wealth, you automatically have more opportunity to get healthcare, to get better education. That doesn't mean that you automatically will, but it means that the likelihood that you will has already increased if you live in a wealthy compared to in poverty. And so when we talk about, and so that's structure, that's policy. When it comes to racism, what we're talking about is that we are socialized on many different levels. So we're socialized both in how we see our parents behave, how we engage, the policies, the systems. So for example, if you go into a grocery store, you'll notice that black hair products are separated from white hair products or textured hair. That is a form of segregation almost, or is kind of delineating that certain people are different. And that's very small. And then when it also comes to who we see more on TV, how, just our exposure. And there's these, so there's so many indications in our systems. And then when we talk about policies, when you go to seek healthcare, who's likely to get what kind of treatment. So it's just it's a gamut. Or if you look into lower, so Dr. Noble Mazzaro had done a study within Pittsburgh on neighborhoods and found that Black neighborhoods had a lower life expectancy than white and wealthier neighborhoods. And so all these things factor in, and it just factors in that we have unconscious bias. Our policies are developed in such a way in which certain people are more likely to get different type of care, and that we are socialized to see things, see people and things in different ways, and that it becomes a structural issue. And it has an impact on someone's life. So, and on someone's well-being, on someone who might be Black or Asian or Hispanic, it has an impact on their well-being, and that's where racism comes in. Did I do that justice, Mario, or?
Oh, I thought, I'm not the judge at all, but you just had me definitely thinking about, and you mentioned Nope, and just I'm also thinking about there. They both do a really good job of putting this in historical context. And if there was one thing I learned from back in my days at the Center for Minority Health, which is now the Center for Equity, was that history matters. We were talking about health disparities and health equities. Because unless you have the historical context of redlining when it comes to housing, discrimination when it comes to loans for small businesses, to environmental racism when it comes to who lives near power plants or just bad environmental areas. And you look at those things and the fact that they play themselves out still today, I think that is where we get at the whole issue of, and again, I'm going to bring it back to even our medical education. Mm-hmm. The fact that there was based on social stratification or social identification. I'm trying to think how Kamara P. Jones puts it, but in terms of who gets assigned value based on how they look, phenotypically look, i.e. skin color, determines who gets access to services and goods. And that has been part of the American way, part of our American culture. And we know that we are still a very young country, and we are seeing these things played out. I'll go back to what I said about syndemics, Dr. Burke, and that is that the stress that people of color have carried for so many years, the burden still plays itself out today. So such that when, and I'm treading into Dr. Mendez's territory here, but such that when we look at maternal child health outcomes, it does not matter if you are talking about someone who has a 5th grade education or someone who is a medical doctor, a PhD, or a lawyer. When it comes to women, Black women giving birth, there is a gradient and a difference between birth outcomes for the most educated Black woman versus the most educated white woman, and all the way down and up the gradient. And so you would say, well, why is that? And once you factor out the things that Chantele talked about, through the socioeconomic status, education, the only thing that seems to be left, right, is this differentiation by this assigned phenotype, which we call race. So I just want.
Yeah, and while his screen is frozen, I wanted to kind of piggyback off of that and say that the issue is not, what research is establishing is that the issue is not race. So the issue is not whether you're Black, whether you're Hispanic. The issue is how you're treated and what you have opportunity to, what you have access to, and so that's how it becomes an issue of racism, not race. Because a person who's let's take a Black person, a person who's Black, if they're given the same opportunity as someone who is white, and there was no racism present, you would expect that they would be able to have the same outcome.
So I think that's really important to underscore, right? That this is focused on the racism piece of it, and what the implications that has for health and well-being. Mario, you kind of must have read my mind in terms of the question that I was thinking about asking you. But before I get there, I just want to point out that our school, each year does a book selection, the One Book, One Community, in an effort to promote, sort of a collective discussion around a health topic. And it hasn't officially been announced, but I'll announce it here, that we solicited recommendations from our faculty, staff, and students, and then we did a voting process to pick the book for this year. And it's Reproductive Injustice, Racism, Pregnancy, and Premature Birth. And so this issue that you were just talking about, the impact that racism and lived experiences have on pregnancy-related outcomes is, there are dramatic disparities there. And that's what's covered in our One Book, One Community book. So we will be announcing that soon, and then announcing related events for collective discussion. So thank you for bringing that up and giving me a chance to plug the book. But what I was going to ask you about is this issue of stress. So you brought it up earlier as an important component of health. And then you talked about it in terms of the historical context and the impact that it has on pregnancy-related outcomes. And I've been thinking a lot about the stress associated with COVID and all of this and what it's going to do for future generations, right? That the experiences of individuals now. And I wonder if you had any thoughts about that, specific to communities of color and others who are being particularly impacted by the pandemic.
Thank you for that, Jess. And I'm glad I bounced back. I think I froze up there again for me. But you know, one of the things I'm currently getting my doctorate in education in the School of Education. And one area that has become really obvious to me is the effect that COVID has had on our young people when it comes to education. And you know, even though my daughter is sitting here, I'm going to talk about her just in this context, in that she is a freshman in college, and she goes to Spelman College in Atlanta, Georgia. But she is having to experience her freshman year at the Pittsburgh campus, living in Browne Hall, right? Which I would know she would rather be experiencing a freshman year in college at her university. One of the ways that I think that it is definitely we are experiencing stress is through our young people are experiencing it through the lack of being able to do things such as go to school, to interact with peers, to have those extracurricular activities. And then when you look in the home, it may be that many in the Black community, parents may be essential workers, working in jobs where they cannot afford to not go to work. So they are both, as a matter of fact, I know some teachers who are not only teaching their classes online, but they're also homeschooling their own children. That just adds, when I think about that, I can't even imagine how stressful that must be. So I think there are many ways that in minoritized communities, in all communities, but even more so, the burden falls in minoritized communities where things that we have come to depend on, we can no longer depend on. It is creating a certain level of stress. And not only that, Jesse, I'll say this other thing, I've been preaching this lately, and that is that I'm going to stop doing what I did today, and that is booking back to back to back to back. Since when did we believe that we could actually do these, every moment that's open on our calendar, we could fill it with something? If we were all working on campus, we would not be doing that to each other. Can you imagine? So we have to, at some point, be able to take an assessment of ourselves, see where we're contributing to our own stress, and be able to do something about that. But absolutely, I think that stress and mental, I hate using the word mental illness,
I'm hoping he comes back because Mario, we missed the last, you hate using the word mental. Well, he's moving very slowly now, so maybe we'll just, Chantele, I'm gonna go, there is a question in the Q&A and I'm gonna go to that and ask it of you.
Sure.
This idea of sharing, could you share with us some ideas that you might have about research that you're interested in the future? I think this is written fairly broadly, but I'm gonna ask you to narrow it into COVID related. Is there sort of in this space, are there research questions that you have?
So one of the things that so I've been working with equity work more within the VA. And one of the things that I've been impressed by is being one of the only African-American women or African-American individuals at all working within the office space, and how that has an impact on my ability to be able to share ideas, but also how that has an impact on creativity and diversity and being able to feel as though I'm represented. And so one of the things, and this is not just my experience, this is many African-American experiences across the nation, across the world, and certainly within the United States. And so one of the issues that I have been focusing, or that I think would be most effective in some of these, with regard to these disparities, is having a more diverse workforce. And so I've been putting more of my attention into developing diversity, equity, and inclusion efforts within workforces to try to raise awareness around that, because I feel like that the more that we have different voices in the room, the more that others can be represented. It's the more that research can be developed so that all people can be kept in mind and disparities can be decreased. And so I believe that if we had a more diverse workforce, where not only it was diverse, but people were invited equitably to participate, that we would see less disparities.
I apologize about fading out again.
It's all right. You said you didn't want to use a word, and then we just didn't hear you anymore. So it seemed to work well. So thank you, Chantele, for answering that question. This piece about sort of thinking upstream and what needs to be done. I appreciate you highlighting that in the workforce and workspace as well.
Yeah, I'm sorry, let me just elaborate one more time, one more thing. And so just doing more research about how to do that better. So more implementation and evaluation research on that. So apologize, I just felt, okay.
Yeah, super important. So Mario, do you want to get back to, you were telling us?
Well, I'll just build off of what Chantele said and connect it. I think I was talking about not only use the mental illness, we're really talking about our mental health and our well-being. And I think that to your point around stress and ways that it's showing up in so many different areas, but even connecting it to what Chantele talked about. We are in a period right now where there is definitely racial battle fatigue for those of us that sort of work in the diversity, equity, and inclusion space, work in the health disparities, the health equity space. And it's quite frankly because there's not, at a predominantly white institution such as ours, we don't have a lot of professionals to turn to. So many of us that do the work every day, we're doing triple time now. And there is a level of burnout. And I'll connect that, Jesse, to the question that you asked about what can you do? And I so appreciate that question. And the question gets answered this way by me, and also gets told to me this way, is that it is not really just Black folk or Hispanic, Latino people's job to educate everyone, that we must educate ourselves. Chantele and I were in a dialogue once where one of our Asian colleagues led the group. And what it brought to my mind was that I know very little about that diaspora and how much I need to find out. I'd like to think I know a little bit about indigenous people and Native Americans here in this country. The reality is that I could learn a whole lot more. And I also learned that it's not proper for me to try to be an expert or talk about their needs. That what I should do is try to use my whatever power I have to invite them in to tell us, to tell their own story. So I think those are some things that we can definitely do to help each other alleviate stress and the burden, and take some of the burden off of ourselves. So going back to talking to people in your comfort zone, Jesse, I say talk to other, say white women with PhDs who are doing amazing work. Start there. And then it can spread out from there. And I mean that wholeheartedly. You are doing amazing work, and I've tried to use some of your work in terms of concept mapping.
You're being too kind, but thank you. I feel the same way about you both. So I really appreciate, I've been thinking a lot about what we've been talking about here, and essentially the themes have been, you know, the context matters, right? Social determinants, sort of where we are, how we exist, our interactions matter, but we don't have to necessarily tackle all the policies and all the issues, you know, at that level, but that you've sort of both reinforced, starting by looking inward too, and educating. I really like, Mario, what you said about start where you are, but don't stay there. And I think that reinforces the idea that we are all able to make some change, and we can all be part of a solution potentially too. And so I really appreciate you taking the time to have this conversation with us, and to you know, move us back upstream, right? That when public health, we talk about, you know, sort of what are the contributing factors, and when we look at COVID and other related illnesses and diseases, you know, we see the deaths and we see the morbidity, but what's really contributing to that, right? Keep moving up to what are the root causes. So thank you both for challenging us to think that way. We are running out of time. It always happens that the hour goes by super fast. And I'm just wondering, I just wanted to give you each maybe a minute if you have any concluding thoughts or things that you want to share with us and the audience before we wrap up. I'll start with you, Chantele.
Thank you again for having me. I agree with Mario and with you, Dr. Burke, that this is an issue that we can all tackle and that we can all work on. It's complicated, but starting where we are and starting to make moves more to understanding the problems on a deeper level is really important. And having lessening these disparities is important for all of us. So
I just want to say thank you as well. Thank you both, Dr. Burke and the very soon to be Dr. Mitchell Miland, for the invitation to hang out with you all and have this discussion. And I would say let's keep having the discussions. And language matters. So we're talking about upstream approaches. We're coming into really talking about moving from even talking about social determinants of health to determinants of equity. So perhaps we can even stop talking about disparities, right? Just plain old differences. We have to even be in.
Oh no, Mario, we lost you for 1 second.
Okay.
We heard the stop using disparities, talk about differences, and then I think you had.
Yes, I was just saying that language matters. We can be intentional about our language, and we should really begin to talk less about the differences, about the disparities, and continue to have these upstream conversations and talk about social determinants of equity. What are the things that we must do to achieve the outcomes that we want to achieve? We already know what the problems are, right? So that's my thought.
Thank you. So the charge for action too, right? That we should remember that our words really do matter a lot, and use them to hopefully initiate some change and action. So I want to thank everybody for joining us. I really am glad you were able to be here. I am glad that you are both at Pitt. We are so lucky to have you here, so thank you both. I hope that people will join us again next Friday when we have Dr. Wendy Browne, who is at the Pennsylvania Department of Health now. She's their COVID response coordinator. She's going to come and talk with us about the Pennsylvania state response to COVID-19. You may know her name. She used to be faculty at Pitt Public Health, and so we're really excited that she will be back with us next Friday. Mario, thank your wife and your daughter for putting up with us for an hour. Safe travels, and I hope everyone has a great weekend. Thanks a lot. Take care.
Yeah.